All right, future nurses, welcome. Let's get you prepped and confident for your ATI pediatric exam. Today, we are laser focused on musculoskeletal disorders. We're talking fractures, congenital issues, and chronic conditions, all the high-yield stuff you need to know from chapters 27, 28, and 29. Let's nail this.
Okay, so picture this. You walk into a room, and there's a 7-year-old who took a tumble off the monkey bars. He's crying, holding his arm, and it looks wrong. It's swollen, it's bent in a way it shouldn't be. Mom and dad are looking at you. So where do you even start? The answer is always with your assessment. That first step sets the stage for everything else you're going to do. So that brings us right into part 1, the assessment. You guys, getting this part right is everything. It's the foundation for your entire plan of care. You got to think of yourself as a detective, piecing together the clues the body is giving you. So let's circle back to our kid from the monkey bars. You're running through a mental checklist for a fracture. You're looking for the obvious stuff, right? Pain, a clear deformity, and swelling. But you're also assessing for things like crepitus. That's that crunchy, grating feeling under the skin. So unsettling. You'll probably see some bruising, feel some warmth, and notice the child is guarding that arm, not wanting to use it at all. All these signs together are painting a really clear picture.
Now, in peds, you're not just looking at injuries. You're also looking for congenital conditions like developmental dysplasia of the hip, or DDH. For infants, you're looking for things like uneven skin folds on their thighs. The provider is going to do the Ortolani and Barlow tests, and they're feeling for this very specific clunk as the hip pops in and out of the socket. You need to know what these signs mean. And here's another one you'll spot right away. Clubfoot. You can just see it. The foot is turned in and pointed down. And speaking of things you can spot with a good visual assessment, let's talk about scoliosis. The key screening for this is having the child bend forward at the waist. What you're looking for is any asymmetry, like one side of the back being higher than the other. Super important screening. And for chronic conditions, you have to know the hallmark signs. And this is a big one. This is Gower's sign, and it's a classic finding in Duchenne muscular dystrophy. You see how the child has to use his hands to literally walk up his own legs to stand up? Why? Because the muscles in his legs and hips are so weak. This is a massive clue that something serious is going on with his muscles. Okay, so you've done your assessment, you've gathered your clues. So now what? What are we actually going to do about it? Let's jump into part 2 and talk about our interventions, our plan of attack. For fractures, the name of the game is immobilization. That's it. It's the absolute cornerstone of healing. The 2 main ways we do this are with casting, that's your basic hard shell, and traction, where we use a pulling force to get the bone lined up correctly, and just as importantly, to relieve those awful muscle spasms. Now, you're going to want to listen to this because this is a huge ATI point. For DDH, the treatment is all about age. For a little baby, newborn to 6 months, we use a Pavlik harness. It's a soft brace that keeps their hips in that frog leg position. But for an older child, say 6 months to 2 years, they'll probably need surgery and then a big restrictive hip spica cast. Knowing that age distinction is absolutely key for your exam. If you have a patient in traction, your nursing care is non-stop. Here's your checklist. You've got to keep their body in perfect alignment. And this is a major safety point. Make sure the weights are hanging freely. They should never, ever be resting on the bed or the floor. You'll also be doing meticulous skin checks, cleaning any pin sites to prevent infection, and doing neurovascular checks over and over again. Of course, medications are a huge piece of the puzzle. For fractures, it's pretty straightforward. We're managing pain, usually with opioids initially. For cerebral palsy, we use muscle relaxants like baclofen to help decrease that intense spasticity. And for muscular dystrophy, corticosteroids like prednisone can actually help increase muscle strength and prolong function. All right, let's move into part 3. You've assessed, you've intervened, but your job is far from over. Now you have to be the watchful eye. You have to be on high alert for complications, because catching these things early can save a limb or even a life. Okay, I need everyone to lean in for this one. The number 1 most critical, can't-miss complication after a fracture or a cast is compartment syndrome. This is a true limb-threatening emergency, and you are the first line of defense. So how do you spot it? You memorize the 5 Ps. First is pain. And I mean pain that is way out of proportion to the injury and doesn't get better with pain meds. Next is paresthesia, that numbness and tingling. That's an early sign. The other Ps, pulselessness, paralysis, and pallor or paleness, those are late, really bad signs. If you suspect this even a little bit, you notify the provider immediately. Time is muscle.
Now, besides compartment syndrome, you gotta know a few other big risk complications. With an open fracture, where the skin is broken, the huge worry is osteomyelitis, a nasty bone infection. For a child with muscular dystrophy, as the disease gets worse, their breathing muscles get weaker, so respiratory failure is their #1 threat. And here's a random but important one for exams. Kids with spina bifida are at a super high risk for developing a latex allergy. Just lock that fact away.
And finally, we get to part 4, discharge. Your job isn't over when the patient heads for the door. In fact, a huge part of your role is just beginning. This is where you empower the family to take over, to be confident and safe caregivers at home. Your cast care teaching has to be crystal clear. You tell the parents, do elevate the cast above the heart for the first day or two to keep the swelling down. Do check the fingers or toes for color, warmth, and feeling. And the don'ts are even more important. Do not get the cast wet. Do not stick anything down there to scratch an itch. No hangers, no pencils, nothing. And teach them that a nasty smell or a hot spot on the cast means they need to call the doctor right away. For a kid with a scoliosis brace, the biggest challenge is just getting them to wear it. You have to really stress that it only works if it's worn for 23 hours a day. You have to be a motivator and an educator. And if a child is going home with an external fixator, you're teaching the family how to do pin care and how to spot the earliest signs of infection, like redness or drainage. See, in the end, your care goes so far beyond the hospital walls. You are literally giving families the tools and the confidence they need to promote their child's independence, to keep them safe, and to be their best advocate. It's a huge responsibility. And I want you to never, ever forget this. It takes just one sharp, compassionate, well-prepared nurse to catch a subtle change, to give clear teaching, to completely change a child's outcome for the better. And that nurse, that's going to be you. So as you're hitting the books for your exam, remember, you're not just memorizing facts about bones and muscles. You are learning how to protect a child's future. Everything you do, your assessment, your interventions, your teaching, it all supports that child's ability to grow, to play, and to develop. And that is the incredible power of being a pediatric nurse.